Welcome to AETCM, the Emergency Medicine channel. So today I will be discussing about the drug Labetalol. So as we all know, it's one of the most commonly used drug in emergency room, especially for hypertensive emergencies. So it comes under the class of drug beta blockers. So we have beta blockers divided further into first generation, second generation and third generation beta blockers. The first generation is basically the ones which has non-selective activity. It acts on both alpha as well as beta receptors and antagonizes both the receptors. So it blocks both alpha and beta. So in that class of drug we have the propranolol, which is most commonly used drug, and if it's a second generation beta blocker, it will be more of a selective beta 1 blocking action, and that class of that drugs will include atenolol or metoprolol, which is most commonly used. So those drugs will come under that, and if in third generation is where labetalol comes, and that is based on the extra activity, which is the vasodilator activity of that beta blocker. So that vasodilatory activity will be present, and again it's further divided based on if it's non-selective or selective. So labetalol comes under the non-selective one, as it blocks both the alpha and beta receptors, whereas the selective one, it blocks mainly only the beta 1 receptors. So labetalol, so it is a third generation non-selective beta blocker with the vasodilatory action. So the mechanism of action, it mainly blocks three receptors: alpha receptor. When you block the alpha receptor, there will be vasodilatory action. So vasodilatation occurs due to the blocking of the alpha receptor by labetalol. Then the beta 1 block causes reduction or decrease in the heart rate, the force of contraction, which is basically the inotropic and the chronotropic activity is decreased, and also the conduction, the electrical conduction is also slowed due to the beta 1 action. And then there is the beta 2 blocking action, which causes mainly vasoconstriction. So that is the main mechanism of action of labetalol. So apart from these three actions, it also has a partial agonist activity. So it has also a partial agonist activity, which is a sympathomimetic activity. Partial agonist activity, which is more like a sympathomimetic activity. So this is basically the mechanism of action. It blocks all the three receptors, the alpha, beta 1 and beta 2, and it produces the corresponding effects. So coming to the pharmacokinetics, so the onset of action, usually it is given as an IV. Is usually given as an IV route. So the IV onset is less than 5 minutes. So it has a rapid onset of action, and the oral route usually takes around 20 minutes to 2 hours, whereas it peaks in IV by around 5 to 15 minutes. So the peak effect will get at a rapid rate, and whereas in oral it will take around 2 to 4 hours for peak action. Duration, it is IV duration is basically from 16 to 18 hours. So that is depending basically on the dose. So it is dose dependent duration of action, whereas orally it takes around 8 to 12 hours for duration. And coming to the metabolism, how the drug is metabolized. So it is mainly metabolized in the liver by the glucuronide conjugation. So the glucuronide conjugation metabolizes labetalol and is excreted in urine and feces. Okay, so that is the metabolism. And coming to the uses, so we all know it's most commonly used drug for hypertensive emergencies. So what are the most common hypertensive emergencies where it is used? So it's mainly used in for example, acute coronary syndrome, or if there is any acute aortic syndromes or in aortic dissection. So in those all conditions, mainly in acute aortic dissection and all, we require a rapid reduction in BP to a target BP of around, for in aortic dissection, the target BP will be around less than or equal to 120. So that's our target BP, and our heart rate also has to be kept at a lower level. So BP target is less than or equal to 120, and heart rate target is around 60 to 80. So both these two effects we can get with the help of labetalol. So, faster rapid reduction we can achieve with labetalol in aortic dissection. Within with other hypertensive emergencies where it is used is in the acute ischemic stroke. So, in acute ischemic stroke for before thrombolysis we will have a BP target of less than or equal to 185 by 110, whereas in case of post thrombolysis our target will change into less than 180 by 105. So, these targets can also be achieved with the help of labetalol. And then other common ones are other hypertensive emergencies as well, and also is used in IC bleed or SAH, SAH and all those conditions it is used. And also in pregnancy also it is a preferred drug, is used mainly for preeclampsia or eclampsia. So, in that also it is used, preeclampsia and eclampsia. So, these are basically where it is most commonly used in the emergency room. So, these hypertensive emergencies we will use labetalol, and also the targets are different, the BP targets are different based on the condition for which we are using the drug. So, in acute aortic dissection and all there will be faster reduction BP is necessary. So, there is no slower reduction required, whereas in case of other hypertensive emergencies usually within the first hour we will achieve around 10 to 20% reduction in BP, and for the remaining 23 hours we will usually take around 5 to 15% of the mean arterial pressure reduction, or the MAP reduction is around that targets will keep, but in certain conditions we will have to achieve at a faster rate. So, what are the basic doses we use for these conditions? So, basically in adults the dosing is will give us bolus doses. So, how is the drug available? It is available as ampule or vial. So, one ampule has around 4 ml of labetalol. So, 1 ml is equivalent to 5 mg of labetalol. So, 1 ml is around 5 mg of labetalol. That is mentioned here. So, 1 ampule is 4 ml, which is 1 ml is 5 mg. So, 5 into 4 will become 20 mg of labetalol is available in an ampule, whereas in a vial, one vial has around 20 ml of labet. So, 20 into 5 will be around 100 mg of labet will be present in a vial. So, depending on that you can take that, and so usually the doses we can give it as either intermittent boluses or we can start as an IV infusion. So, if you are giving as an intermittent bolus, the dose is 10 to 20 mg. So, initially we can start with 10 mg or 20 mg, and we usually give over a period of 2 minutes, not as a rapid bolus, but over 2 minutes we will be giving slowly as a bolus. So, this boluses we can repeat every 10 minutes, and we can go on increasing the next doses from 20 mg to around up to 80 mg we can increase the doses. So, that is how you give intermittent boluses in these hypertensive emergencies. And in other conditions like if we are not able to achieve the target BP or the target reduction is we are not able to achieve, then we can start the patient on infusions. So, how do you give an infusion? So, infusion the dose is usually 0.5 to 2 mg per minute. So, that is a starting dose we give 0.5 mg per minute, and we can increase up to 2 mg per minute. Maximum dose we give is 10 mg per minute. Okay. So, I will just tell you in a bit how you prepare the infusion for giving as a continuous infusion in these emergencies. Also the pediatric dosing also you need to be knowing. So, the IV bolus dose which we give as intermittent bolus doses is 0.2 to 1 mg per kg per dose. So, 0.2 to 1 mg per kg will be our intermittent bolus dose, and maximum we can give up to 40 mg in pediatrics, whereas continuous infusion will start with 0.25 to 3 mg per kg per hour. So, it is per kg per hour, where here it is per minute. So, that difference also you have to know. So, IV infusion is 0.25 to 3 mg per kg per hour. Okay. And if you are giving as oral route for chronic hypertension or resistant hypertension, then the dose will be 100 mg BD, and we can increase the dose 200 to 800 mg per day, that much we can increase the dose. Okay, so how to make the infusion? So how do you make the infusion? So we have discussed earlier, one ampule has 4 ml, 4 ml, each ml is 5 mg. So 5 into 4 will become 20 mg in a ampule. Okay, so to make the minimum dose of infusion is 0.5 mg per minute. So 0.5 mg per minute will be equivalent to 30 mg per hour. So you do into 60 will become 30 mg per hour, and 30 mg per hour when you calculate for the ml, 4 ml is 20 mg. So 30 mg will be around 6 ml. So 6 ml per hour will be the starting infusion dose, and then we can increase the rate by increasing 6, or we can make it 12, we can make it 18. So that way we can go on increasing. So it will become 0.5 mg per minute, 1 mg per minute, 1.5 mg per minute, like that we can go on increasing the dose. Okay, so that is the infusion one. Usually we give mainly only intermittent boluses, and if required only we should start on infusion. So that thing also you need to know. Then coming to the adverse effects. So adverse effects, what all we have? So coming to the CNS adverse effect, usually the patient might have some fatigue or lethargy, generalized weakness, or can have some sleep disturbances, or some mental depressions can also be seen in certain people. So that is the CNS ones. The CVS ones are more important. So it can mainly cause bradycardia. So always you have to monitor the heart rate. So it can cause bradycardia. Then it can cause heart block. And then other things it can cause is, it can cause orthostatic hypotension. Orthostatic hypotension or syncope. So those things it can cause in CVS, and flushing and all can occur. Whereas in respiratory system, since it blocks the beta activity, it can lead to bronchoconstriction or bronchospasm can occur. Bronchospasm can occur. So that should also be, we should also be cautioned about, take precautions about that as well. And coming to the gastrointestinal manifestation, mainly it is nausea, and sometimes vomiting episodes or diarrhea episodes can also occur. Then metabolic adverse effect is hypoglycemia. So basically the action of the beta receptors is actually it causes, it inhibits basically the glycogenolysis. So the glycogenolysis is actually inhibited, and this prevents the further production of glucose. So the patients who are taking like anti-diabetic medications, those people will have a more chance of going into hypoglycemia, and when you give labetalol in such patients as well, there are more chances for hypoglycemia. And also it masks the signs or symptoms of hypoglycemia, because the tachycardia, the palpitations, the sweating tremors, all of these sympathomimetic activities are cut off by labetalol. So the patient might not have any symptoms of hypoglycemic symptoms. Those symptoms won't be usually present. So that thing also we'll have to make note of. Okay, and then other thing is, as with every other drug, it can have hypersensitivity reactions or anaphylaxis as well. So and also the skeletal muscle blood flow is also reduced, so there can be some weakness as well. Okay, so these are the most common adverse effects of the drug. So so what we have to take precautions, what precautions we will have to see before giving the drug. So we have to see if the patient is having a bradycardia. So if is the patient having any bradycardia, or is the patient having any heart block like more than the first degree heart block, like second or third degree heart block, those patients also we should try to avoid giving this drug. And also in bradycardia patients, it will cause further bradycardia, and that will be an issue. Then other thing is, we'll have to see if the patient is an asthmatic patient or a patient with an obstructive airway disease. So these patients, it can also exacerbate the bronchospasm. So that thing also has to be seen. And in hypoglycemic patients, or in patients using anti-diabetic drugs or hypoglycemic agents, so those patients also, there are more chances of going into hypoglycemia, and the patient might not show any symptoms of hypoglycemia. So that thing also we need to see before at the administration of labetalol. So hope you have understood a brief discussion about the drug labetalol. Thank you.